you. I think the order was really wonderful, whoever put the agenda together, because the continuum of alphabet soup that is payment reform all feeds into better coordinating people's healthcare needs, but also their social services needs, as you begin to make the connections about getting people not only the care they need, but getting them to the doctor, getting them the kinds of supports that they need to be successful in the healthcare system. So just to, I hope, to tell you about WellCare real quickly. WellCare was established in 1985. We're based in Tampa, Florida. We serve approximately 2.7 million members. We are exclusively public programs. So we do Medicare, we do Medicaid, we do CHIP. In New York, they have a program called Family Health Plus, which will go away as they move towards the exchange, but it's an adults program. We serve people throughout the continuum of population served by public programs. So from well babies and their moms to people in need of long-term care. We have capitated long-term care programs in 2 states. We also offer Medicare Advantage plans and a Part D plan in 49 of the 50 states, and I don't know why not Wisconsin, so I apologize if you're from Wisconsin. The focus of our plan is really on folks at the lower end of the socioeconomic spectrum. So while as a Medicare Advantage plan, of course, we take all members, we are really focused primarily on people who are dually eligible for Medicare and Medicaid, and people who are very near that socioeconomic level in our Medicare products, so that our focus is really on very needy communities. As a part of the WellCare family of companies, we have a WellCare Community Foundation and an Advocacy and Community Relations Department, the whole focus of which is creating these public-private partnerships, as were described by the last speaker. WellCare itself is a Fortune 500 company. We're ranked number 18 in the Barron's 500, and we have more than 4,500 associates nationwide. What we try to do is to create a model to deliver quality health care that is personalized to each market in which we deliver care. What we've learned, especially in treating these highly vulnerable populations, is, you know, the typical phrase, you've seen one Medicaid program, you've seen one Medicaid program. Truly, you've seen one Medicaid program, and in some states, based on different eligibility categories, you've seen 1/5 of a Medicaid program, right? Because you've seen only that group of people who you're serving. And so we have a program, a health services program, that is divided between those elements of care management that can be easily and cost efficiently done in a centralized way, call centers and stuff like that in locations all over the country that do things like member outreach calls and initial health risk assessments over the phone. And then we have field-based care management people who are literally in your communities, if we're operating in your state, who are identifying those folks who have more substantial healthcare needs and going out and trying to figure out not only what is your healthcare need, but what are the barriers that are making it hard for you to access the care that you need. The Robert Wood Johnson Foundation did a study that found that 85% of the physicians they surveyed said that unmet social needs were directly impacting the quality of their patients. And so if you look at that scale on the left-hand side of the slide, it shouldn't be terribly surprising, right? People initially are interested in their clothing, food, shelter, right? Those very basic needs. And then further up the scale is education, employment, income, family and social supports, and community safety. And only when those needs are met can you really move the needle on access and quality. Because if I'm the primary caregiver of my 3 children's children, and I'm in my late 50s, and I don't have child care, I'm not going to go for my preventive screenings, because I probably also don't have transportation, and I don't have any way to meet all of those other needs that come up as a result of having both unmet health care and unmet social needs. So I'm going to tell you a story about a real family that we serve in Kentucky. This is a rural family. There are 6 family members. There's a mom and dad. The dad had a corporate job, lost his job as a result of cutbacks. Neither mom nor dad had health insurance. There were twin sons. I'm sorry, my slide says one son. There were twin sons, one of whom is developmentally delayed, a 19-year-old daughter who's pregnant, and the 73-year-old grandmother who was is diabetic and also is showing signs of early dementia, moved in. So you've got a family that's really in crisis. Our program went out, the field-based care managers I described to you, assessed the needs of the family, and then worked with the community, and I'm going to show you how in a second, to connect them with the services available in their community to meet those other needs that have nothing to do with their health plan. So support services for the pregnant daughter, heating assistance, a subsidized loan to buy a car because they were having transportation issues. In order to put them back on their feet, they had to be able to get to the job, right? They couldn't find a job till they could get to one. So we worked with them in those ways. And then we worked with, there had been a food bank at a faith-based organization. The food bank had run out of funding and they had gone out of business. And so we gave them a grant along with others to reestablish the food bank, to make sure that this family and other families had access to the food they needed. I'm going to skip over and I'll show you this part and then I'll come back. So how did we do it and what did we do? We have built what we call the Health Connections program that is based on a very large database that tracks the public assistance programs available in the specific market. And we do that via talking to the people in the community, your states, if you have a 2-on-1 program in your state, if there is a United Way directory, if there are directories of faith-based organizations, all of those inputs go into this database. And then what we begin to do is to track not only the community activities that we're doing, but also community activities that are posted, referrals that are made, and this connects into, on the back end, our care management database. So the nurse care manager that's dealing with the fact that you have uncontrolled diabetes can also see whether you are or not referred to the right community organization that might be able to help with some of the reasons, for example, that you don't have access to the food that's necessary for your diet to control your diabetes, and can integrate both the social and the medical aspects. In partnership with that, right, we don't do this. The community advocacy organizations do all this really fine work. What we do is we partner with them to make sure that our giving strategy as a company is aligned with the needs of the communities that we serve. So that where we find that there was a food bank and there isn't anymore, we don't only go in and fund it, but we also work with other organizations in the community to help fund it so that it is a sustainable model for them that doesn't rely on one giver or one sponsor. We also work with other groups that are similar, that are treating similar communities to assure that the services that we're delivering to our folks are aligned with and not duplicative of services that they're getting from other places. And so we assemble data. We could do it we are now doing it at the zip code level. We're looking at the viability of the social safety net in the area that we're serving. And then we're implementing programs to fill those gaps. So now I'll go back to where I was. I think why, right? So you know why we're a Medicaid company. We're judged on outcomes. We're judged on getting people the care they need. But we're also watching the demographic data. And this is a new study about a week ago, came out from Kaiser. And they went back and looked at census data using the federal poverty level as defined by the Census Bureau, and the adjusted federal poverty level among seniors, if you were going to adjust for things like the federal poverty level doesn't, which is regional variation, the cost of living. And what they found is that the share of seniors in poverty is higher in every state with this, using that supplemental measure. and at least twice as high in 12 states, and you can see that's the difference between their maps. And the share of seniors living in poverty under the supplemental measure is especially high, 1 to 4, meaning 1 out of 4 seniors are living in poverty in the District of Columbia, and 1 out of 5 are living in poverty in California, Hawaii, Louisiana, Nevada, Georgia, and New York. We have health plans in California, Hawaii, Louisiana, Georgia, and New York. So that's why. What does this look like? So this is our care management model I described. The little crayon people are a little hard to read, I'm sorry. But what, to the previous speaker's point, what those care management teams look like is that the blue person is the member. And the people who work around them are, like me, social workers, community outreach folks, behavioral health professionals, and then health, physical health professionals, either an RN or another, depending on what their issue is. And those folks are assigned to a member who's in need of care management based on their primary presenting condition. So if you're profoundly mentally ill, then a behavioral health professional is your primary care manager, with assistance from the other folks on the team with you for your other needs. If your primary presenting issues are more, I don't have food, I don't have heat, then the person who's spending the most time with you is that community outreach coordinator. And then our network is the medical home that you heard described earlier. And whether or not that's an NCQA accredited medical home, and which level of NCQA accreditation that entity has, or whether that is our designation of that person as somebody, as primary care provider, depends a lot on the capacity of the network to be a patient-centered medical home or to be accredited. And so while I think everyone agrees it would be wonderful to have all providers be patient-centered medical homes and have that technology capability and have the ability to provide the connections that is supposed to represent, the reality is that in many of our communities, you've got very overworked providers that are facing an incoming storm of additional enrollees as a result of healthcare reform, who are saying, that sounds great, but I'll get to that at some point, right? But I can't do that now. So what we do is, in essence, those functions with them and in partnership. In partnership with them, in some cases for them, but usually in partnership with them. Or if they have, we have several relationships where they actually have those folks. They're a fully functioning NCQA accredited patient-centered medical home, and some of those roles they're taking on. So in Georgia, we just implemented a patient-centered medical home program. In New York, they have a very robust health home program, and we participate in that. What the green things represent is the social services funding. And so what has happened since the beginning of the recession is a reduction in social services funding, which has resulted in cuts of about 40%. And so you're seeing the need go up, the funding go down, and the groups like ours, and we have contemporaries here from Molina and AmeriGroup, and they see the same things. I'm sorry, WellPoint. That we are held accountable for the quality of someone's care, but the services they rely on to even access that care are diminishing. And so that's why we've taken on this role.